I don't care how many years you've been practicing forensic pathologists, when you see something on that scale, it just becomes very difficult.
Welcome to the Sober Spill podcast. I'm your host, Isabel. On this podcast, we have real conversations with people in recovery, their families, and organizations that pertain to this field. Today, I'm here with the host of the clinical side of our podcast, Jana.
Thank you, Isabel. My guests will discuss best clinical practices, new emerging trends in substance use and mental health disorders, and how we can best take care of ourselves and our loved ones in recovery.
See you every Thursday.
And come spill with us soon. Today on Sober Spill, we're honored to welcome Dr. James Gill, Chief Medical Examiner for the state of Connecticut and a national leader in forensic pathology. Dr. Gill's work spans clinical science, public health, and the justice system. With over 100 peer-reviewed publications and decades of experience testifying in state and federal courts, Dr. Gill brings a rare and vital perspective on how we investigate death, drive prevention, and shape our understanding of substance use-related mortality. Dr. Gill has been the Chief Medical Examiner of Connecticut since 2013. He's overseen Connecticut's arc of the opioid crisis. Dr. Gill has analyzed, certified, and tracked thousands of overdose deaths as fentanyl, heroin, prescription opioids, xylazine, and polysubstance use have evolved. He's seen firsthand how families and communities are impacted, the patterns in relapse deaths, the impact of stigma, and the tragedies that don't make headlines. In addition to his leadership in Connecticut, Dr. Gill is the past president of the National Association of Medical Examiners, serves on faculty at Yale Medical School of Medicine, has held academic appointments at UConn and Quinnipiac. His publications have focused on death investigation, drug intoxication, fatalities, and the intersection of forensic pathology and public health. Today's conversation takes us into a part of the public health system that very few people ever see firsthand, the Office of the Chief Medical Examiner. Thank you, Dr. Gill, for being here today to help educate us on what the patterns behind fatalities can teach us about prevention, treatment, and hope. Welcome.
Thank you. Thank you for inviting me. Happy to be here.
Thank you. So you've built an incredible career at the intersection of medicine, law, and public health. First, I was hoping you could explain to us all what is forensic pathology, and then also what drew you to forensic pathology.
So forensic pathology is a part of medicine that deals with the laboratory aspects of disease and injury. It's part of pathology. It's a subspecialty, actually, of pathology that deals with the investigation of sudden, suspicious, or unnatural deaths. And we typically investigate those by performing autopsies. So forensic pathologists, after getting your regular pathology training, you then have to do an extra year, a fellowship year in forensic pathology to become then board certified in forensic pathology. So I probably first got interested through my parents, actually. My father was an attorney. My mother was a nurse. So I didn't know if I should go into law or medicine, and I guess I kind of combined them both. But kind of growing up, I would sometimes go to the courthouse in Litchfield and watch my father. He had maybe a homicide case or something, and I would go sit in on that. And then in college, I spent the summer at the State Police Crime Lab with Henry Lee, and I did an internship in their serology section. This was before DNA even. I'm dating myself. And then in medical school, I spent a summer at the Connecticut Medical Examiner's Office, and I really found that was the thing that I liked the most. As you said, it's kind of this intersection of many different things: public health, families, physicians, police, testifying in court, something different every day, and it's trying to figure out what happened, and I found that very interesting.
Yeah, that is interesting. So it really started quite a long time ago, piqued your interest, and it does sound like a very interesting, diverse career. I've heard you say that in a few different recordings I've watched of you, that every single day is different, and I'm sure you've seen, like I mentioned before, so many changes in the different types of deaths that we've seen in Connecticut. And I was wondering if you could share a little bit about that, just sort of what experiences have shaped your understanding of the changes you've seen over the past few decades.
Yeah, we're seeing a lot more technology now in forensics, including expanded toxicology testing as well as DNA testing. We're finally getting into that area that clinical medicine has been using for years. Forensics only really used it for identification, and now we're using it for diagnoses, for determining why someone died, and that there are two benefits to that. One is obviously determining why the person died and having an accurate death certificate. The other is that many of these diseases are hereditary. So you can actually then benefit the living by identifying something in their family that they may be able to treat or intervene in to prevent another death in the future. So I think some of the newer, and I guess radiology also has an expanded role in forensics, such as CT scanning and so forth. So those are kind of the three newer areas that I've seen grow over my career as a forensic pathologist.
And I wonder when you talk about some of the technology, if you're seeing an influx in AI, especially maybe with the recording, is AI helping at all expedite getting some of the reports out? Or
A few weeks ago, I was at the National Association of Medical Examiners annual meeting, and there were some presentations on AI, and some of it is having to do with report generation, where you can kind of just give all your findings, and then the program will put it all together into a format for you. But the other area that someone had presented on was looking at gunshot wounds,
wow.
and they had put in hundreds and hundreds of examples of entrance and exit gunshot wounds, and then had to see how AI could diagnose them and make the correct diagnosis. So there may be ways in diagnosis as well as a guide, maybe not the definitive determination, but as a guide.
That's very interesting, seeing how that might change and help guide the process, but also help with the reports, getting the reports out. This may seem like a simple question, but I know one thing people asked me when I was preparing for this interview is about sort of the differences between a death certificate and an autopsy and how the chief medical examiner's office interfaces with those two different pieces of a death.
So what happens when a death happens in the state, there are certain deaths that by statute have to be reported to our office. And usually they're ones that are unexpected or related to injury, or there's something suspicious about it. So only a medical examiner can certify deaths that are unnatural. Those mean that those are homicides, suicides, accidents. And so that death gets reported to our office. We do an investigation. If there's a scene where the body's outside the hospital, one of our investigators goes to the scene, examines the body, takes photographs, writes a report. The next day, we all kind of meet and decide which deaths need autopsy examination. And so that autopsy is going to help us kind of determine why the person died. There's usually a question, is it a natural death? Is it an intoxication death? And so then we perform the autopsy, and you may have heard of the Y-shaped incision, where we look at the internal organs. We collect various tissue samples for testing. And the goal of the autopsy is to help us determine the cause of death. Why did the person die? Is it an intoxication? Is it a cancer? Is it heart disease? Is it an injury? And then once we determine the cause of death, then we're going to issue an autopsy report, which lists all our findings, as well as the death certificate, which is the legal document saying this person died on this date, at this time, in this place, and this is the cause of death. And then as medical examiners, we also list the manner of death. Mm-hmm. Only medical examiners can list manners of death that are not natural. So again, if it's a homicide, a suicide, or an accident, only medical examiners. This office is one office in Connecticut.
One office for the entire state. 11 medical examiners for the entire state of Connecticut.
The entire state. So we certify, over 3,000 deaths a year. Again, those are the ones that come under our jurisdiction.
Wow. I mean, we know from the work I do, I think that we've seen where families have been waiting for the results of the autopsy. For many people, it can be especially challenging if their loved one died of an unnatural cause and they want to know. They desperately want to know what happened, what was in their system, and the wait can be agonizing. So I'm curious, what I guess to be blunt, what causes the wait and the delay? And this isn't about putting blame on. It's just more genuine curiosity. What
Sure.
causes that? What I've heard is like 6 to 8 weeks typically.
Usually, we kind of give that for the final report. So, if the person's dying from clear trauma, a gunshot wound, usually we would certify that death the same day. We don't need to wait for additional testing, toxicology testing, or what have you. If it's a question of an intoxication death, then we need the toxicology results. And unfortunately, it's not like television where they put the sample in the machine and you get the result and boom. We send it out to actually a private forensic lab that has a very broad scope of testing. And generally, on average, we get most of our reports back within a couple of weeks. I'd say about, if there's nothing detected, we get it back maybe in a week. If they find something, because it's a forensic lab, they not only need to look for all these different drugs, but then confirm that they found them and quantitate them. How much is actually there? And there are many different types of tests different pathways that they need to go. So it actually does take some time. Now, when I first started in Connecticut here, we were doing the toxicology in-house, and there's a backlog of several months. I mean, we had to wait 4 or 5 months to get a toxicology report. And you can imagine, what families were waiting for. So we've improved that, down to now usually a few weeks. We usually can get those results back. And I've certified a couple deaths now that occurred a couple weeks ago, and I called a family, and I do try and give the families a call when we get those results back, so they don't have to wait for the report to come out or the death certificate to come out. That they can get those results in real time. Not only does the family want to know, but they also may be waiting for insurance benefits too, right? So some insurance benefits may not pay out until they get that final death certificate. So that's another thing that the families are waiting for, funeral homes are waiting for. And so we do have that. We know about that. We're aware of that. We do try and do the best we can to finish up those death certificates as quickly as possible.
So you actually make those calls to family members yourself personally?
We do. Yep.
Yeah.
And, sometimes it's the day of the autopsy. We may, the family may want to know right away if we found anything. And sometimes we do, and we can tell them right then. Or sometimes we say we need to wait for further testing. And then when I get those results back, I make a note in my chart, say, give the family a call, and I call them up and I tell them. Yep. So I think a lot of people don't realize, forensic pathologists, we do have a lot of interactions with families,
Yeah.
When a person dies in the hospital, they speak to the doctor, and that's kind of about it. But we have this follow-up because they do have questions, and that's what we really are trying to do, is trying to answer their questions.
And you came in at an interesting time. I think back to 2013. I was working in substance use disorders then, and we were starting to see more fentanyl. We were starting to see kids come in using fentanyl patches and hearing of more people overdosing in the community. And there was starting to be this ripple effect of more community awareness of there's an opioid crisis, but what was that like at the time when your office had this, a large list of toxicologies to go through, and then you're seeing, I assume, new different types of overdoses and different types of deaths at that time?
Right. When I started in Connecticut, I think we were seeing about 300 to 400 accidental drug intoxication deaths a year, and maybe 5 or 10 would involve fentanyl. And again, usually they were the patches.
Yeah.
And then we saw a tripling of that over the next 10 years, literally. I mean, our autopsy numbers went from 1,500 autopsies a year to over 3,000. Our drug intoxication deaths went from 400 to 1,500 a year. So now we've come down to this past year, 2024. I think we had about 950 accidental drug intoxication deaths. So it's under 1,000 now. So we've started to see this decrease. But yeah, we didn't have enough staff. We needed to hire more medical examiners. We're running out of space to store remains. We needed to get refrigerated tractor trailers. We've outgrown our office in a way. We were kind of fortunate that we were able to kind of keep up with hiring of staff during that time, but a lot of offices weren't able to do that because there's a shortage of forensic pathologists. The country only has about half the number that they really need. So many offices don't have enough forensic pathologists, and so they have to make some tough choices. And a lot of offices, or several offices I know of, have stopped doing autopsies on suspected drug intoxication deaths. They just rely on the toxicology testing. And to me, that's not great forensic practice. You're going to overcall some deaths, and you're going to miss some deaths, misclassify some deaths without doing the autopsy. In order to certify a death due to an intoxication, you really need three components. One is the investigation, the circumstances. The second is the autopsy to exclude other causes of death. And then the third is the toxicology. So you need to look at all those three factors. And if you don't have all those three factors, you're going to make some misdiagnoses.
Wow, that there's a lot to unpack there. I'm just thinking, first of all, the national shortage, only half the forensic pathologists we need, nationwide. Why do you think we have a shortage in this field? That seems so interesting. And I know people have asked you before with CSI and sort of the proliferation of all these, TV shows showing off the field. Why aren't more people going into it?
And yeah, I'm actually, the TV shows, I think they do help, exposing what we do. It's not quite like that, but, one of the issues is, so in order to become a forensic pathologist, you first have to do regular hospital pathology, anatomic pathology. And if you were to stop there and work in a hospital as a hospital pathologist, you would make a lot more money than as a forensic pathologist. Whereas a forensic pathologist, you have to do an extra year of training, a fellowship year, and then you're usually going to be working for some public agency. And people are graduating medical school with $300,000 in debt, and they have to make some hard choices, So fortunately, I think the salaries in forensic pathology are increasing because of this shortage, because of this demand. And so that is improving. I'm hoping that more people will, get into forensics, but we see usually about 40 to 50 new forensic pathologists each year. And we really, I think we've got about 800 or so full-time practicing board-certified forensic pathologists in the country, and we really need probably 1,600 to cover all the jurisdictions in the country. Right now, there are jurisdictions that don't have forensic pathologists.
Wow, yeah, 800 nationwide is definitely doesn't sound like enough. Wow, I heard you say something to the effect once of, in order to live well, we need to understand the way we die, and really recognizing the importance as a culture and as a society of understanding death. And going back again to your work in Connecticut, you were again overseeing the state in such a pivotal time where people were starting to understand that we were in the middle of a crisis, especially for young people, and especially maybe for populations that hadn't been affected previously with a substance use disorder crisis at that magnitude. How did you help sort of the state understand what you were seeing and the importance of we prevention funding or needing more resources to deal with this new opioid crisis, and also the families you were calling? There must have been families at the time that didn't know what fentanyl was. It wasn't on the news every day in 2013.
It's still in a way being called heroin. We still get deaths. Oh, he died of heroin. And it's not going to, we see very little heroin nowadays. But forensic pathologists, we really do think of how our work can help the living. And in the New York City Medical Examiner's office, there's a Latin inscription, and it translates, "Let conversation cease, let laughter flee. This is the place where death delights to help the living." We really do think of how can our work help prevent future deaths. And so our data is the hardest data you have about the extent of the opioid crisis. It's tough to measure how many people may have overdosed and been rescued at a home, or maybe survived and went to the hospital and survived. Those numbers are difficult to track. So we really have some of the hardest data there is to show what's really happening to this crisis. Plus, we have this really excellent toxicology results. If you go to the hospital, they can do a little screening test. And, for many years during this crisis, some hospitals weren't even testing for fentanyl. They were just testing for a general opiate screen. So we can really get an idea of what the drugs are out there. and what role they're playing in the deaths. So then people can try and address those and make some interventions about those.
Hi everyone, Pat McCarthy here. Mountainside offers a healthcare professionals program for physicians, nurses, dentists, and therapists. Our team of board-certified addiction specialists provides discreet, comprehensive treatment for substance use and co-occurring disorders. We are here to help you achieve sustainable recovery with a plan built around your unique needs. Reach out to admissions@mountainside.com for more details.
And what happens when you encounter a death that you don't know what the substance is? Or how does that work? Or when you realize that this death is caused by something, but it's not something we're testing for?
Right, so that does happen, and especially with the fentanyl deaths, we're seeing all these fentanyl analogs, right? These new structures of, essentially they were fentanyl, but they would put a little different chemical group on it, which would make it more difficult to detect. So, for example, we had a case, I remember, where a person was found dead in their home. There were drug packets, there were syringes. We did the autopsy, no disease, no injury. We sent out the toxicology, and it was negative. Nothing was detected. And I'm like, this is clearly a drug intoxication death. So in that case, what we did was, well, there are a couple of things. One, we can ask the lab to do a little more testing, kind of experimental testing, to see if they can find anything. But the other thing we can do is we sent the drug packets from the scene to the state crime lab. And it's much easier to test for drugs in a powder form than in a biological, a blood sample. So they were able to actually detect this new fentanyl that was there. And then we told the toxicology lab, our lab detected this. Can you now develop a test to look for that in the blood? And they did. So then we're able to identify a new type of fentanyl that was on the street.
That is incredible. That really is amazing, sort of that kind of detective work and putting the picture together and how that can help prevention in communities. You know, if communities don't even know it's there. Approximately how many different types of fentanyl are there? Like,
oh boy, yeah,
I know it's like a moving target. I don't know if we can put a number on it, but
probably a good dozen, I would think. You know,
okay.
I mean, just because of the different things they've been adding to.
Yeah.
Carfentanil is one that we don't see that much anymore, but it's a very potent version of fentanyl, and I think that's one of the problems with fentanyl is that it is so potent, it's so strong, it's very difficult to dose. So you don't have a chemist or a pharmacist who's putting these drug packets together, right? And so just a few extra little granules of the drug can be the difference between life and death. And that's, I think, because of its potency, that's one of the reasons why we saw this increase as well in deaths.
Wow. What other substances are you seeing occur now at this point, where we are? Because I think a lot of the community that I speak to in regards to people that use substances is really trying to stay away from opioids. They're really trying to stay away because they know that fentanyl can be in everything. I mean, sort of the expression fentanyl is in everything. And we see it, people test positive with that, say they've only been using cocaine, but yet they'll test positive for fentanyl as well. Are you seeing an increase in other substances?
We're seeing a lot of the fentanyl deaths with cocaine as well. So that's a very common, mixture. Or we see it also with benzodiazepines, so like Valium. And usually Valium, generally by itself, it's a relatively safe medication. But if you were to mix it with another opioid, then there's a synergistic effect that's not good. I guess the combination of drugs are something that we're still seeing. Xylazine, is something we saw quite a bit of in Connecticut. It got a lot of press, but in actual fact, and we do include it in the cause of death statement, but I think it plays a very minor, if any, role in the actual death. Usually it's a very low concentration, and I think the fentanyl is really kind of the dominant drug in those deaths.
And what do you make of the overall decrease in overdose deaths in Connecticut? I mean, it is exciting to see, and when you were sharing those numbers of how many less autopsies you're doing that are related to overdose deaths, what do you make of that?
I think it probably really is a combination of factors. One, I think that the quality, so to not to say that it's good drug now, but I think maybe the drug dealers have gotten a little more careful with the dosing, as well as selling it in a pill form as opposed to a packet form, and maybe more people may be smoking fentanyl than injecting it, and so smoking it, I think there's been some studies that have said it may be a little safer than injecting. Other things, obviously therapy, improved access to therapy, better therapy, fewer relapses. And then I think just prevention, getting people exposed or preventing people from getting exposed in the first place. And a lot of that falls on physicians. And I think physicians have to take a lot of the blame for some of this early part of the crisis where they were overprescribing opioids. And so you're exposing the people opioids who may not have normally needed to be exposed, and they have, maybe some chemical issue that they become, they're more prone to addiction than someone else. And so by having something like the prescription drug monitoring site, so the state can monitor prescribers, better prescribing habits. We have a role with the Consumer Product Safety Department.
Okay.
So whenever there's a death from an opioid or from any drug intoxication death, they get notified, and they do two things. One is they will notify the pharmacists to stop issuing that prescription, and then they will also reach out to the doctors who have prescribed that patient any benzodiazepines or opioids and notify that doctor that their patient died from an intoxication death, just to make them aware that, okay, this happened. And so maybe they will learn from that and be a little more careful maybe in some of their prescribing habits in the future.
Yeah, that's so incredible to actually have that feedback loop. I don't know if other states have that as well, or is that something specific to Connecticut working with the consumer?
That's something that I think of a few other jurisdictions have it. Most jurisdictions have that prescription monitoring site now, which is very good. But as far as that notification link, I'm not sure how widespread that is. I think there's another component too, which I think is kind of probably the saddest part of it, and it's kind of called a cohort effect, where the people who are greatest risk have died now. And we're hopefully preventing new people from getting that addiction. And so hopefully that's one of the, the reasons why that, we're preventing people from becoming addicted in the first place. But unfortunately, people who were addicted, they're not making, either they're getting treatment and getting off the addiction, or they died.
Yeah, I mean, those are huge numbers, that you mentioned before. What about Narcan? What role do you think Narcan might play in the potential decrease?
I think it certainly plays a role but probably in limited circumstances. Remember, you need to have someone there to give it, right?
Yes.
And there's a window where you have to give it. And we've had Narcan has been accessible for many, many years, right? And so, it's tough to know how many people it did save, right? That's kind of unknowable in a way. So maybe without the Narcan accessibility, we would have even seen higher numbers. But I don't think it's just the Narcan. Otherwise, why are we seeing this decrease in the last couple of years as opposed to, 8 years ago when Narcan was available then too? But again, maybe there were deaths that it prevented that we just don't know about.
I think though too, Narcan is a lot easier to get now for free than it was 8 years ago. I think a lot of people now do carry it more frequently, and there's a lot of sites.
I mean, I have got one on my desk here. I mean, I've had it for years. We've had it in the office. I think every bit helps. But again, there's that window. You have to be able to get to the person when before they've had any brain injury, essentially. Yeah.
Wow. It was interesting hearing you talk about benzodiazepines. I mean, we're definitely seeing an increase in people using benzos. And then, hearing a lot about designer benzos, people buying these benzos off. And that's actually the other factor I want to ask you about, how the web, like the internet, has changed your practice too, because people can get anything from all over the world now. So, for example, designer benzos from Italy, you can get shipped to you right in your home in Connecticut. And you don't even have to go out and go to a drug dealer or go somewhere that you might not want to go.
Yep, and I mean, there's another class, nitazines, which is
Yes.
another, synthetic opioid. Again, it can be, we're getting better at detecting it, but it's also out there. So yeah, it's something that we're always having to. The toxicology labs are always struggling to keep up on things, looking for the newest drugs out on the street. And I think that's where, again, law enforcement and getting some of these drug packets that they get during an arrest, testing those, because that's a good way to look for what drugs are actually out there, and then we can look for them in the blood, which we may not be able to find them at this point.
Can you explain to our audience what nitazines are? Because we're seeing them, that word come up, it comes up on like TikTok and different places, but what are nitazines?
It's another kind of synthetic opioid class, and they're different. They have these weird different names, but it essentially is an opioid type drug. So it's going to affect the opioid receptor, but it's just another, I think it was made originally by a pharmaceutical company looking for another type of opioid. And we've seen some other ones with actually just kind of chemical names or numbers, that just kind of pop up. And so that's what everyone's kind of concerned about with that. If we start missing detecting some of these, then we start missing some of these deaths. So I think a lot of the experimental labs, the investigative labs, are very interested in trying to develop easy testing for these drugs, but it's essentially a synthetic type opioid. Yeah.
Wow. And are you seeing any kratom related deaths, or your team seeing any mitragynine?
We do see it in some of our drug deaths. Usually it's with other drugs. It's very rare. I think maybe one or two, and there've been some other reports where you can see extremely high concentrations where people take a lot. But generally, when we see it, it's usually in combination with fentanyl or another drug, and I think that other drug is probably the dominant drug. We will include it, though, because at higher concentrations, higher levels, it can have some opioid, type effects. Yeah.
Definitely. I mean, we're seeing a lot more people struggle with 7-OH, the press pills that are supposed to be like 13 times stronger than morphine, and they're legal and they're out there and
Right.
very addictive for some people. Going back to calling the families, this must, families are obviously must be in a really difficult place when they get this news. They've already lost their loved one. Are there family members that don't want to acknowledge that there was substances, that don't want that on? I don't know if they have any control over like what's on the death certificate.
Yeah, there are some families that usually it's more an issue when we have suicides where they don't want suicide on the death certificate. But there were some, I've had families say, please don't put the word heroin on the death certificate. From a well-to-do family or something. Oh, we can't. My wife, she'll be too upset, and I say, I'm sorry, but it's illegally I have to do it. And second, this is the only way we're going to know what's really happening. I mean, I can't cover up these deaths. We need to know what the specific drugs are. And medical examiners used to certify a lot of these deaths as multi-drug intoxication, or polypharmacy, and not list out the drugs. No, now, I mean, there's a big push from the vital records folks, CDC. Everyone want to know what are the specific drugs. Otherwise, it all goes under the radar. We wouldn't have known about this fentanyl issue if we just certified these deaths as multi-drug intoxications, right? So we really need to spell those out so people know what we're dealing with.
Yeah, what's in the community and what's accessible. Again, coming back to so many substances now are accessible online. A lot of the traditional barriers are gone to obtaining substances. So it's definitely a lot coming down the pipeline. So the more open, honest conversations we can have as communities, I think the better of knowing what is there, what's out there, and sort of the reality of that.
And again, going back to, that idea about, you don't know what's in that drug packet, right? I mean, there's no FDA on the street, so you never know what you're going to get. And I remember, Several years ago, I turned on Channel 8, in New Haven, and they said last night there were 16 overdoses. And when I hear overdoses, I think of fatal overdoses. Unfortunately, they weren't. I think only maybe 2 or 3 people ended up dying from that. Most of them were rescued, but they all thought they had bought cocaine and they were snorting it. And it turned out it was a mixture of cocaine and fentanyl. And they started to lose consciousness, and EMS was called, and they were able to be, Narcan and resuscitated. So again, that's the thing. You just don't know what you're getting in that packet.
Yeah. And then again, you see a lot of cases that maybe don't make the headlines too. You're seeing them all. There have been some really sad cases the past few years, particularly of infants or young children overdosing. And it's horrible to see those types of things in the news, but my only hope is that that can lead to the reality for all the different social service agencies, Department of Child and Family, that this can be a reality and that we have to be really guard and protect, our babies that don't have a choice in those situations if they're in an environment where there is fentanyl.
Right. Yep. No, we see, there's kind of a difference between, say, an infant who really, is different from a toddler. A toddler who can be crawling around, can pick up a packet and swallow it, and there's enough drug in that packet for a toddler to cause an overdose. We actually would call those homicides because you're allowing, there's a neglect component where you're allowing a toddler access to an illegal drug. And whereas the infants, generally those infants are dosed. They are given the drug intentionally because they can't pick up a packet and swallow it inadvertently. So those are generally certified as homicides as well.
Hi, I'm Ricky, recovery support clinician. Mountainside's Bespoke Recovery offers the highest level of luxury addiction treatment. With the focus on your privacy and schedule, you'll receive intensive one-on-one therapies from our expert team. Enjoy exclusive amenities and concierge services, allowing you to seamlessly integrate healing with your life commitment.
That is really incredibly heavy work. How do you support your staff in doing that work? I wonder too, if you ever get staff that they find, this happens to me, at least my work can be heavy too, that this isn't the field for them. They get into it with a genuine curiosity and passion, but the work on the day-to-day is very real. And I assume there can be some secondary trauma from this work.
Yeah, I think we get through it by supporting each other. We all, by working together, and you do focus on the science and the medicine, but there are always going to be cases that are just, they're just, something that we've never seen or just so tragic. I think usually the problems for most forensic pathologists occur when it's on a large scale. Like I wasn't working in Connecticut during Sandy Hook, but I know the office, when you see, it's one thing to maybe see one child, but when you see multiple children, or, I was in New York during the World Trade Center. So seeing that volume of case, that gets to everybody, right? I don't care how many years you've been practicing forensic pathologists, when you see something on that scale, it just becomes very difficult. And we do have other support groups. There's an employee assistance program that people can access. We have a rescue dog come into the lobby, once a month. And again, just supporting each other, talking about cases, sharing things. That's, I think, how we all kind of work and get through things. Yeah.
That's incredible. And did you say you actually have a support group for the professionals? Like, is there even like a national forensic examiner support group?
There is a National Association of Medical Examiners has a special committee for kind of workforce assistance, that type of thing, because that's something that we're all becoming aware of. So there are different talks. We've had a little mini symposium on it that was available. And every now and then we can have, EAP come in and give a talk to us, or, have someone come in and, or even just doing something social. We'll have a potluck lunch or an ice cream social or something, just to, do something a little off the beaten track.
Yeah, that's really good that you are able to support each other. And you've been in the field for so long, so being able to share some of those experiences. I wanted to clarify, when you said the World Trade Center, were you referring to the bombing or 9/11?
So, yep. So 9/11, I was working in the Manhattan office. I remember I was doing an autopsy on a man who had shot himself. And one of the techs came in and said a plane just hit the World Trade Center. And then another one. And so then everything came through that office, the Manhattan office. So we all set it up, we set up a triage section, and most of the remains were fragmented remains, and no autopsies were done. It was really just a matter of identification at that point, and DNA became, the way that most of the remains were identified.
That is incredible. But you were really literally there with the remains then, with them. How do you think those experiences have informed who you are, that you've, especially too, I mean, that's a sort of a global tragedy that you were really incredibly close to.
I think forensic pathologists, we have a little, like, we always wear our seatbelts, I'm not a big fan of elective surgery, I mean, I've seen so many medical complications, and they're very rare, but we see them all. So to us, it looks like they're a lot, So I think maybe we're just maybe a little more careful about things, because we do see how, we are always thinking about prevention, and we don't want these things to happen. And so how can we try and help prevent them? And we do that by, if someone has an adverse reaction to a medication, we report that to the FDA so they can track those, right? We participate with Bridgeport Trauma Service. Monthly, we will present all the cases that came through their ER that died, and we will give them what we found at autopsy so they can learn. They may say, I didn't know the person had a broken neck, or an aortic injury. And so they get follow-up about, and may be able to help them when that next patient comes in, to save that person. So.
Well, thank you so much. It's such an incredible conversation. And thank you for the work you do. It's really incredible work. And Connecticut's lucky that we do have, sounds like a really robust medical examiner team. I'm sure there are communities in the country, like you mentioned, that probably don't have the access to have the level of commitment and the scope and level of education and practice that your team has had. So I'm really grateful that you stayed in Connecticut to do this work and sort of be helpful in the prevention of these crises. We didn't even get to COVID.
That was a whole nother.
A whole other thing. I know. I need a little break from thinking about it, I think. But what would you like to leave our listeners with? What do you think is important for them to know about your field?
I just really like to thank you for giving me the opportunity to share with what we do. I think that is the most important thing, kind of the takeaway for me, is that people understand kind of what our role is, what we do. We're not just, doing a homicide. There's a whole other area of our work, a public health work, a bereavement work with families. And I think just realizing that there's a bigger part of the medical examiner's office than just a little bit maybe you see on TV.
Very well said. Thank you so much, Dr. Gill. Thank you for your
Jana.
time today.
If you or a loved one is struggling with addiction, Mountainside can help. Call 860-365-6764 to speak with our caring treatment team.